This conference will now be recorded.
Okay. Let's see. It's kind of sad. I don't even remember what these cases are, even though I downloaded them 2 seconds ago. So this is, take me a second to remember. Let's see here. Okay, so this is more of a, I don't know, kind of a consult. I mean, I think I know what it is, but I was just curious what you guys think. So here's a guy comes in and for an ILD study, but has this kind of ball of fat with a linear calcification along the edge. He had a study um, about a year before, and it's not surprisingly unchanged. Here it is in other planes. You can kind of see there's a little nubbin going through it, a little vessel going through that area that's then looks like it's almost partially calcified, kind of as that vessel, you can kind of almost followed in and then goes into this thing that's partially calcified and eventually comes out. I called this an old case of healed, I don't know what you want to call it, epipericardial fat pad necrosis, pericardial fat pad necrosis, blah, blah, blah. Would you guys think of anything else for this?
That was my exact thought.
Yeah, no, I mean,
I
that's
think it's in the right place, and I think your calcification is probably the little pedicle of whatever thrombosed and torsed.
exactly, exactly.
That's
And
beautiful.
that's what you can see, the look, kind of that calcium goes right into this little vessel here that goes through it. So that's what I assumed it was, and I called it just healed epipericardial fat pad necrosis with a torsed pedicle of the vessel. I don't think, I mean, I've seen them acutely. I don't know. I've seen maybe 3 cases acutely. I just haven't seen one that's healed. And I was wondering if anyone thought anything different. Okay, well, that makes you feel better. And here's the old case. I'll include that from a year ago that shows that it's completely unchanged. Um,
I mean,
this
Seth, the
is,
only other thing it could be would be like a lipoma that torsed, but it's
that's,
effectively the
yeah,
same thing. So
yeah. Um, which one is the first one here? So here is, see if I can get these all side by side. Let's see if this wonderful system will let me do that. Multi-data volume browse. Sorry, this might take a second. But this is interesting. I don't think I've seen this to this degree. So this is 130. So here are, if I can get that, it's not going to let me do it. Okay, so I'll have to kind of blow these up. So these are 2, I know this is kind of painful, but there are inspiratory exams on the left and right here. This is, I'll just blow this. This is the original study. And you can see there's some bronchial wall thickening. It's moderate-ish, especially down in the lower lobes. You can see, again, nothing that surprising, no real bronchiectasis or anything. The expiratory study really shows, really quite severe air trapping. I mean, there's posterior bowing of the trachea, um, and he was quite symptomatic. Um, and you could see that, well, the airways are kind of collapsing here, touching each other. I don't know if that's a little bit of plug, but anyway, so this is him. He undergoes like an extensive steroid treatment, and this is him a few months later. Still has some airway wall thickening, but it's definitely better. Oh, no, sorry, that's the same one. Where's the? Why won't this pull up the new one? Son of a. Anyways, it's not letting me, for some reason, pull up this one here, which shows that the bronchial wall thickening is a lot better. But what's really impressive is that here's the, I don't know why this is not going to let me do it. Anyways, we'll put the middle, you'll see here. This is the expiratory imaging from when he had his severe kind of asthma attack. And then here's his expiratory imaging after his treatment. And it's really, you can see how much air trapping there is. Like, for instance, the left lower lobe on this old one shows no collapse whatsoever. And it's completely normal on follow-up. And there's a bunch of other areas, like here in the right middle lobe, you can see there's pretty severe air trapping. Anyways, I just thought it was I don't think I've seen air trapping improve like that, because usually we think of air trapping as, some sort of small airway fibrosis, but it could also be severe inflammation, which the small airway inflammation did resolve with the improving of the asthma. So I just, I showed this to Lynch, and he was saying he doesn't think he's seen a case that's resolved so pronounced in a short period of time. So I don't know.
That's pretty cool. Yeah, because I think a constrictive bronchiolitis. I mean, I guess that's true fibrosis. Well, I mean, it depends. Like, it could be a transient constriction, but like the true constrictive bronchiolitis we think of as irreversible.
Yeah,
Um,
exactly. So this is, small
and he
airway
wasn't.
inflammation from asthma.
And when he presented with the first scan, was that like acutely, or is it just sort of like he came as an outpatient and this,
No,
he wasn't?
it was kind of acute. So it was an outpatient, but he came in because he was worse symptomatically. We're not an ER place, but it wasn't like he had to go to
Right.
the ER. He was acutely much worse.
Okay,
And
so
then
maybe like a mild status asthmaticus.
and then they treated him, and then this is his follow-up, and it's like night and day.
That's
Both.
great.
I think it's probably a sampling problem, Seth, because if somebody gets better, there's no incentive to do a repeat CT. So you got lucky this time because they got you one. But normally you wouldn't see the improvement on on the dilators.
Yeah, this was many months later, and they switched all his meds around.
Hmm.
And I don't know exactly what they did, but just looking
Hmm.
at the history, he was severely symptomatic here in January, and he was symptomatically much improved on this follow-up. I don't know exactly what, but you can see the large airways themselves as well are much less thick. Like, look
Right.
here, the large airways themselves, I mean, they're still thick, but they're not as thick. So
Hmm.
there is some diffuse improvement, at least on imaging of that airways disease. But I agree, it's usually not this impressive. At least I've never seen a case like that. And it's a cute case. I mean, we've seen probably a lot of these, but um, I was kind of didn't have a ton of cases to show. So, but there is one question. So we could see this bubbly cystic lesion filling smaller cysts, filling the superior segment. There's no bronchus there. There's this little muted bronchus that doesn't connect. So there's a bronchial atresia with this plugged up bronchus here going to the CPAM. Um, the only thing I was wondering about, that kind of, so I was reading about this, and I guess technically this would be, not that we're pathology, but the cysts are smaller than 2 centimeters. So I guess this would be, I don't know, technically a type 2 if we're, but there's this bubbly nodularish ground glass thing in the CPAM, and I know there's an increased risk of adenocarcinoma, but I mean, I just said to follow it up. Would any of you guys think anything with this? I'm sorry, I gotta take this phone call.
So I'm going to anticipate Seth's question is, would you have done anything differently? And probably reasonable just to get a follow-up. I mean, I don't know, we tend not to touch the CPAMs in adults. I've not seen one become problematic um, in an asymptomatic patient. But yeah, I think if there's any soft tissue component that you can't explain, it'd be reasonable to get a follow-up, just make sure it doesn't change. And if it's stable over a reasonable period of time, you could let it go.
Yeah, it looks too not. Anyways, but I was just reading that supposedly adenocarcinomas are a common complication of the type 1 CPAMs, but not the type 2 CPAMs. But again, I don't know how confident I am of that diagnosis per se, just based off the cyst size without pathology. But who knows what they'll do? It's just really a CPAM with bronchial atresia. Anyways, that's all I have.
Cool. All right, I have a few I can show. Let's see. All right, you guys see my screen okay?
Yeah.
All right, so this is a young woman. She's like in her, I want to say, mid to late 20s. She's had a couple of children and presented with long-standing arm and breast swelling. And this is her CT scan here. And you can see the fibroglandular tissue is markedly increased and edematous compared to the other side. The skin is thickened. But there's all these channels and you in the axillary fat too. And as you follow it down, you can see she's got all these little channels in here. And apparently had swelling in her arm. Even the vein is dilated here. So with the longstanding history and all that in her age, this is not cancer, but rather just like lymphedema and probably from some kind of lymphatic malformation. I don't have any other imaging on it. The history is helpful in that the longstanding nature of it, but we don't often see something like this. But these are all dilated channels here in the axilla. And there's that, I always forget what it's called, one of those eponymous syndromes that can be associated with these lymphatic malformations, but just kind of a weird case of that. I'll show the coronal as well. But you can see that even in her arm, what we see of it here, you have all these dilated channels here. So, otherwise you'd be worried about like an inflammatory breast carcinoma and something bad like that, but not in this case.
So,
All
Jeff,
right.
no history of trauma or surgery or anything like that.
No. She nursed 2 children, but on the other side, just with the right breast. But no, it's been long-standing. It was like over a decade of this history, no trauma. So presumably developmental. I'm going to show this case last because it's the most complicated. This was just kind of a cool case, and I've not seen this. This is is this the right one here? Yeah, this is a 70-year-old guy. He's being treated for a cancer. But what caught my attention was this bright white thing crossing from one rib through the retrosternal space to the other side there. And at first I was wondering, was this a staple line? But it didn't make sense. It went across. And then if you look at the sagittal, right window there we go. You can see that his sternum isn't quite right. It's kind of bendy looking here. And if you look at where this passes by in there, it's classic of a Nussbaum procedure. Now he's 70, so it wasn't in the immediate chart, but I finally dug around a little bit. He had a remote pectus repair, but we don't usually CT them afterwards. So this is what it is. It's just kind of interesting how it, that we see it. They don't get in the lung, so it's just kind of pushing up, tethering the pleura a little bit there. But I presume it either caused some dystrophic calcification or the bar did something to the periosteum, and this is actually cortical bone here. But I just not seen that before. It's just kind of an odd finding. I still see these done every so often, but I've never seen one long term. All right. This case is just kind of a fun one. This is a 25-year-old male, presents with cough, fever. You can see he's got consolidation in the left lower lobe. There it is. It's kind of rounded, no pleural effusion. So he was treated for infection, didn't get better immediately. So they got a CT scan here. And you can see this area is quite heterogeneous. There's some low attenuation in it. The vessels pass through it. The airways kind of drop out. It's very lobulated. Some, again, areas of low attenuation. And you'll see there's no pleural effusion. And there is some lymphadenopathy, but it's modest. You got some lower lobe nodes, some hilar nodes, this one chunky subcarinal node. So this is a case of acute blastomycosis. I haven't seen one in a while. We see a ton around here. It's been a while since we've seen them. This is a little unusual time of year, but you can happen. And we had a fairly dry summer, so there wasn't as much dying vegetation. But it can look really ugly, like a cancer. He's 25, so less likely. And the reason I pointed out the effusion is that that can be helpful. Most bacterial pneumonias, in my experience, have some pleural reaction when they're this big and up against the pleura, and you just tend not to see that with blasto, where it's a small effusion. And the degree of lymph node enlargement is usually disproportionately small, unlike histo, where we get big chunky nodes. And again, even bacterial infections tend to be cause more inflammation. If you look on the soft tissue windows, I mean the lung windows, you can see it's pretty well circumscribed, but has this blobby appearance and some satellite nodules as well. All right, this last case is cool, and my colleague Daniela came across. We've all seen this patient because the patient's been here a long time, and I'm trying to figure out how to get them in the right order. But this patient has COPD and underwent gotta get the right one here, underwent endobronchial valve placement. So we're doing a lot of these here, and you can see these are the Zephyr valves right here. That's our preferred valve here, and they pick the lobe with usually the most emphysema and also the best fissures. And one of the complications that occurs in these patients is they can get a pneumothorax afterwards from the rapid volume loss, and they can also get a post-obstructive stuff. So this patient did fine immediately post-procedure, and I'm going to get these all in the right order. And then you can see, let's see, maybe it's this one. Yeah. So here he is, the next image, and you can see he's starting to lose a little bit of volume here on the right. He is rotated, but it looked like it was starting to lose a little bit of volume. And then he developed a pneumothorax, which does happen. And you can see that they put a drain in there. And sometimes these persist. And I wonder if a component of this is ex vacuo, because you really haven't violated the pleura, but rather you've caused a rapid collapse. But we reported this as ex vacuo. They put a tube in anyway. And it's been percolating along for some time. And what's interesting is with the pneumothorax not draining, that also favors an ex vacuo phenomenon. You can see that the right upper lobe is opacified, presumably because now we've occluded it and it's trying to collapse down, but it's unable to. So long story short, he's been hanging around here for a couple of weeks. And let me find the next one. Yeah, here's another one here, showing just that dense, now consolidated. There are the valves. But there is a 2 view down here somewhere. Yeah, so here he is now on a more recent radiograph. So now we've got this right upper lobe here that's partially collapsed. There's some volume loss, but now we got this fluid level here. On the lateral view, you can see it's here. So it looks like it's in the lung, but it's actually in the pleural space. So he underwent a CT scan, and there's a couple neat findings here. So in this collapsed right upper lobe, let's see if I can find him here. Yeah, so here in the right lower lobe, you can see these little pneumatoceles, and he's got a lot of debris in his airways, and then he's got this just loculated effusion, and then here's the right upper lobe here, all now nice and collapsed down. The valves did their job, but we'd not seen these pneumatoceles before, and Daniela did find a paper that did report them. It's not a known complication, and our pulmonologists had not seen it, but it's one of these weird complications. I can't figure out why you get a pneumatocele other than there's just rapid shift in pressures, and that it's sort of like an endobronchial trauma with the increased pressure doing that. I don't know if any of you have ever come across this before if you're doing these valves.
So Jeff, this is in the lung. It's a pneumatoceal that's in the lung. But did you say earlier that there was something in the pleural space, or did it just that it looked as if it was in the pleural space?
I'm sorry. Yeah, I'm sorry. It looked like it was pleural there. Yeah, my bad.
Okay.
Yeah, he's got this pneumothorax, but it's kind of rounded here, so you wonder about the lung, but it appeared rather quickly. And then he's got this, big one up here as well. And if we look at
And before they placed the valves, there wasn't a CT showing a big bulla in this location before?
There's no bulla.
Okay.
Yeah, we always do a planning CT, but that's one of the contraindications sometimes. If there is a big bulla, they won't put a valve in that lobe. But yeah, okay. One of these weird ones here.
Jeff, I do have a case in case if Seth is still on, because it causes me some puzzlement here, and I wonder if you guys can tell me what's going on in somebody's left atrium.
Yeah.
So let's take a look. Let me find my go-to meeting. It disappeared. Here it is. Stop sharing.
So let me see if I can. So can you see a two-for CT scan?
Yes.
This person had CT PE protocol in an outside hospital and has this bizarre filling defect in the left atrium here on the on this view. I've never seen anything like this. It doesn't really seem to connect up with a pulmonary vein. The pulmonary veins are densely opacified, so I don't think it's an inflow defect. And it looks kind of polypoid, so it looks bizarre to me. And then here it is on coronal. It's right up here. And Karen Ordovas took a look at this and said, "Oh, that is a pectinate muscle or something like that." So I haven't looked that up yet. Is that a familiar entity to you? This thing
Yeah, I
is
mean
bizarre.
that's in the differential. I mean that's along the Coumadin Ridge, right? So that it could just definitely it could be muscle that is does happen there. I mean, if we saw something like that, and it depends, it could be clot. That's a known area for clot to occur on. I mean,
Hmm.
and then you get into weird things like I've seen papillary fibroblastomas in that location. I've seen one
Okay.
myxoma in that location, but I think it probably is just muscle, but there's no priors or anything.
No, should we get an echo on him? Do you think we should work this up?
Um, how does it look in? Because that coronal is a MIP. Do you have like a coronal or sagittal that's just a regular thin
Let's
slices
try
that's
this.
not a MIP?
Yeah. Yeah, this one's better.
Yeah, it's right on that Coumadin Ridge. I mean, that's it's probably just an accessory muscle bundle. I don't know how you exclude a clot. Um, Unfortunately, echo is not going to be good for it. They'll just say, "Oh, it's something there." Maybe I mean that's a place to start, I guess, and see what they want to do. It's one of those things where depending on the patient and the symptomatology, they can always get an MR to confirm it's muscle, but or you know, clot or something else. That's usually pretty easy to distinguish. But
So MR might be the way to go. Okay,
MR
but
will give you the definitive answer. It's so expensive. I mean, echo I think is a fine place to start. I think it's fair to say it's likely just a band of muscle, but it would be hard to exclude a clot or even a
so
you know.
Seth, doesn't this look sort of more irregular and stuff like that than a muscle band? I would expect a muscle band to be smooth and
Yeah,
linear,
it
and this thing
does.
looks
That's
polypoid.
why I'm saying it's a little like if it's just that linear part, it wouldn't bother me, but that's what is kind of bothering me a little bit is the inferior aspect where it's a little more papillary frond-like.
You know,
And that's why I'm suggesting that. I mean, if we had really thin slices and you could see little bands of muscle extending across to the other side of the atrial wall, maybe,
you
but
know.
um,
Okay,
I think Karen's probably right. I wouldn't I personally would probably get something to confirm.
okay, that's very helpful. This guy had the reason I was looking at this old study in this guy is he came this morning for a sniff test because this guy was he works at high altitude at a ski resort. He was walking in, he was getting off a shift where he'd done some lifting and stuff like this. He had in the parking lot, he had sudden onset of severe chest pain and shortness of breath. And it sounded like a pulmonary embolism to me. So he had left chest pain. He does have some atelectasis in his left base. So this CT scan was done a few weeks after that or months after that acute episode, and it was done for PE, and there wasn't any PE. The guy is still short of breath and still has vague chest pain at this point. So when I saw something like this, I thought, did he embolize something? Did he have a transient occlusion of, say, a coronary artery or something like that, and it was getting left chest pain for that reason, and it's subsequently resolved? But um, I think it'd be
I
good
think
to follow
an
this
echo
up.
is Yeah, I think an echo is fair.
Okay, good.
They'll probably say the same thing, probably muscle can't exclude, and then you're going to go to the MR, but I would start there
Okay,
versus doing the
got it.
MR. Yeah.
Good. Thank you.
Yep.
All right. Yeah, I wasn't going to be able to help you on that one, David. Okay, well, I think that's it. We'll end a little early. So, yeah, take care, everybody.
Okay. Thanks very much.
All right.
Yeah, I think
Take care.
Howard's on his way back to the U.S. He said, I think his last weekend in England was this past week. So
Oh, really? He's coming back? I didn't know that there was a plan to come back.
I think he was just there for 6 months. I don't know what his long-term plans are, but
Okay. All
yeah.
right.
All right. Take care.
Walden.
Bye.
Walden too. Thank you.
Bye.